Ladies and gentlemen, my name is Malyugin. I'm from Moscow, Russia, and will be sharing my experience with iris suture fixation. Iris suture fixation can be used in 3 different clinical scenarios, such as backup IOL fixation in complicated cataract surgery cases, as a secondary option in FIK cases without capsular support, and also as a refixation technique of IOL capsular bag complex dislocations. There are several techniques. However, we have to credit Malcolm McCannell, who introduced transcorneal retrievable suture technique, which was later improved by Dr. Suture, who proposed to retrieve the loop of the suture outside of the anterior chamber and suture the knot outside of the eye, and then by pulling both threads, both ends of the threads, placing the suture inside the anterior chamber. Gary Condon taught us to utilize 3-piece foldable acrylic lenses, and Walter Stark made this technique of folding the 3-piece IOL and engaging all haptics into the posterior chamber and placing them simultaneously with the forceps. There is another method to be mentioned, which is utilizing intraocular manipulation with a special instrument designed by Dr. Ike Ahmed. IOL options, obviously, these techniques is more suitable for the foldable acrylic 3-piece lens, and it should be emphasized that the anterior surface of the optic should be rounded to avoid depigmentation of the posterior surface of the iris. Suture options are different. However, my preference would be polypropylene 9-0, which is more durable comparing to 10-0 and will stay longer with time. Here's the clinical case number 1. Residual cortical material is removed with the vitrectomy probe. Now 3-piece IOL is inserted into the anterior chamber, haptics positioned behind the iris, and now I'm using the long needle, passing it through the cornea, catching the haptic of the lens and going out of the eye in order to achieve secure fixation of this haptical element. The suture loop is retrieved, and then I pass usually 3 times the tip of the suture inside the loop, and by pulling both ends of the suture, the haptic is fixated, and this maneuver should be done 2 or even preferably 3 times in order to achieve secure fixation of the haptical element. The ends of the suture are pulled apart, and as you can see here, scissors introduced through the main incision are used to cut the end of that suture, and the same maneuver is done in the opposite side of the pupil, where the second haptical element is engaged. And please mention that at that point, when both haptics are secured, the optical element is prolapsed behind the pupil. Finally, I check the anterior chamber for the presence of the vitreous strands. So this is another clinical case of a patient having megalophthalmos, extremely deep 8 mm anterior chamber, and Francois corneal dystrophy. And in that case, the wide to wide diameter was exceeding 15 millimeters. And I'm checking the size of the rhexis, and we know that in these particular cases, the capsular bag is extremely fragile. And this resulted in rupture of the anterior rhexis, and rhexis radialization was leading to extension of the tear towards the periphery. During the surgical procedure, it was necessary to remove epithelium because there was slight epithelial edema. Cortical material was removed from the anterior chamber, which was quite safe. And as you can see here, the lens was placed, and in spite of the fact that this is extremely huge and very deep and large anterior chamber, these manipulations were very successful. And what we can see here is that the suture fixation of the one of the haptical elements, and one white arrow represents peripheral coloboma. As you can see here, the vision was quite good in that particular case. So the third clinical case scenario is patient with IOL capsular bag complex dislocation, as shown here. In these cases, it is quite important to catch the haptical element, and because this was a single piece lens, that was not so easy, because the wide haptical element of this particular IOL model. And in these cases, you have to suture through the iris, through the bag, around, place the needle around the haptical element and go out. And it is a good idea to fixate both haptical elements without tying both sutures, because you actually can see the size of the pupil, and you avoid pupil avalization and peaking in the direction of the suture that placed in this area. So again, I'm passing my needle 3 times into the loop, which was exposed after externalization of the suture material, and by pulling both ends in the opposite direction, the knot is tied and it is placed inside. Sometimes it's a good idea to try to check if the pupil margin is mobile and there is no peaking of the pupil, as shown here. And after that, the suture was tied, and I'm using micro scissors to remove and to cut the ends of this polypropylene suture. And these are actually final steps of the surgical procedure right here. And you see the pupil is central and the lens is in the stable position. Here's the same eye 1 week after the surgery, and green arrows showing you the areas of suture fixation. There are some complications that can happen with this technique that are very common in different other suture fixation techniques. And there are advantages of minimally induced astigmatism, and this technique is much less challenging than scleral fixation. To conclude, iris suture fixation is an excellent surgical option. It is extremely helpful in various surgical scenarios. It's not immune to complications. However, if used properly, it provides good and stable clinical outcomes. And I thank you very much for your kind attention.